I welcome you all on the second day of the first National Midterm CME organized by Indian Association for Child and Adolescent Mental Health on the theme Young Mind and Behavioral Addiction. Tonight, myself, Dr. Anita Atokpong, will be your MC. May I now take the privilege to welcome once again our respected chairpersons, learned speakers, moderators, today's panelists, quizmasters, observer from Manipur Medical Council, and all the delegates. Yesterday, we all had a very interesting scientific session, and today also we would like to mention that we are planning a very exciting and interesting scientific program for all of you. And before we start on with our scientific session, may I take the privilege to announce once again that two credit hours will be awarded to those delegates who attend all the scientific sessions for 2 days. So I request all of you to kindly stay tuned till the end of our scientific program, and also kindly ensure clicking on the logout button instead of closing the browser, because your logout time is being captured. So without wasting much of the time, let us start today's first scientific session. For the first scientific session, we have Dr. Manoj Sharma as our speaker. And before that, to chair the scientific session, I would like to invite our chairpersons, Dr. Maneesh Gupta and Dr. L. Roshan Singh. First of all, I would like to introduce Dr. Maneesh Gupta. Sir is a consultant psychiatrist, MD Psychiatry, and gold medalist, KGMU. He has completed specialist training CST Adult Psychiatry, London. May I introduce our second chairperson, Dr. L. Roshan Singh. Sir is working as an assistant professor in the Department of Clinical Psychology, RIMS, Imphal. He has 21 publications and has been involved in 5 research projects. May I now invite our chairpersons to kindly come on the dais and introduce our speaker. May I now hand over the session to our respected chairpersons.
Thank you, Dr. Anita. So it is my privilege to begin today's session. And for the first session, our speaker is esteemed Dr. Manoj Kumar Sharma. He is a reputed, renowned professor in the Department of Clinical Psychology at NIMHANS. He is credited with starting the first technology de-addiction clinic, known as SHUT Clinic, sane and healthy use of technology. And that has been a really great hit among people. His area of interest lies in treatment of technological addiction and overuse and developing screening tools for them. He is a member of the WHO expert group on addictive behaviors, and he has 109 publications. I invite Dr. Manoj Sharma now to take over and start his presentation, please.
Thank you. Thank you, Dr. Mahesh.
Please go ahead.
And thank you, the team, for inviting me. And since our time constraints are there, so I would just focus on important aspects of intervention. And I focus more on technology addiction because addiction is a broad domain. So I thought I would just focus on what else we can do for the management of technology addiction. So what are the research indicates? Research indicates like internet addiction.
Dr. Sharma, sorry to interrupt. Can we put it on the slideshow mode, please?
Just 1 minute.
Thank you, sir.
So internet addiction, I think it's already might have been discussed, but I will just go over some of the important facts. The internet addiction is associated with personality traits like low emotional stability, low agreeableness, low extraversion, and virtual identity versus real identity, which blurs the boundaries between the real world and the virtual world. And this we have seen broadly as a pathways to online chatting. Some of these also act as a pathways for cyber sex, as well as we recently published one case on how the person shift from gaming to gambling. And we have found similar kind of pathways for those conditions also. So that way I can see that these are some important domains which we have to manage while using our psychological or behavioral interventions. And among these, like shyness, sensation-seeking behavior, loneliness are also associated with internet use. So I think the psychological aspects goes with like I'm a loner, I'm a moody, and I don't care what others think of me, and that's why I'm on the technology use. So what goes in intervention is affirmation and acknowledgement to remain abstinence. So like I think it could be as a simple any interview setting where we say the last week you have been able to move away from different situations and you had the urge to play games, but I'm happy that you shared with me. So this is like one affirmation. And people say we have made a good progress now and we know that you will cope up with the stress also. And then it says that you affirm it like it is a good technique, you are using it and it's better to avoid it and focus on other domains of activities which can be helpful and which can develop your interest in leisure activities. So these are some of the cognitions which we have to screen in clinical setting as well as in our clients. One is blaming. People blame that it's not he or she, it's like the factors in the environment. Like it could be like it's not internet, it is a stress in my life. I need internet to deal with the problem in my life. And my parents, school and spouse drive me to the internet. Or it could be excuse also that it has been a long day. Internet helps me to relax. Nowadays, people watch show series in the late night hours, and because they feel the whole day was productive, and I want to relax myself. Or it could be like it is good to use internet at night since I was studying, working throughout the day. And it is similar sort of logic is used by substance user also that I have been productive, I am contributing toward the family, so nothing wrong if I enjoy my drinks in the night without disturbing anybody. Rationalizing another psychological factors people use to maintain it. One is using internet is not as bad as having alcohol. And this is my reward for hard day work of the day and I can relax. Minimizing is like it is nothing, it is just a smartphone and computer, nothing much. And people don't give much relevance to this addiction property of the technology use. Though gaming has become a clinical condition, but still they feel they can manage it. But whenever the time comes for management, it's become out of control from them. Gaming is not as bad as people feels. So, and then again, people do likes to share chats, comments and other things which comes. And we have seen recently, like one paper is under acceptance where we found that young adults come across various addiction content on social media platforms, either in terms of advertisement or in terms of chats and all. And we have seen people who are more exposed to this kind of chat and advertisement, they have higher tendency to experiment with substance use in their lifestyle, in their lifespan. So it's mean there is a need for social media literacy amongst youngsters. So now what I think this is some initially I'm focusing on what we can do as a part of brief interventions. I'm focusing on 2A approach. One is assess, second is assist. The assess is assess yourself for use of technology or assess others for use of technology. It can be done for 3 domains. One is recreational use. Recreational use, like where we find the use of technology is in the healthy domain, where person feel good, person has high productivity, person has good social connectivity and other things. But this recreational use may become a problematic use when it becomes habitual. It's habitual when I'm saying some of the symptoms might have been come up for discussion, like people experience nomophobia, people experience zero inbox syndrome, people experience phantom vibration syndromes, or sometimes because of our expectation, people do experience digital burnout because of problematic use. Because nowadays webinar and Zoom meeting has become common, and we have seen after 30 to 40 minutes of any webinar meeting, people do experience burnout symptoms also. So I think that all parts of problematic use. Then comes the addictive use, where person has preoccupation with use of technology, loss of control for use of technology, and continuous use despite having consequences in one's lifestyle. So if these three things are coming up, then we say person has addiction to technology. So the best way to start with any intervention is a screening. This is 5C approach we evolved in our clinic. Stand for craving is continuous desire to access technology. Answer is yes and no. If yes is there, that's become first yes toward addiction. Second is control. Do they experience loss of control for use of technology? That's become second yes. Third is coping. Are they using technology as a method of coping to feel relaxed, to overcome stress? If that is there, that's become third yes. Fourth is compulsion. It's become a habit for you. You can't be without technology. Nowadays, people use mobile phone or check mobile phone 60 to 70 times per day. And sometimes it is more than that also. So 70 or 80 times if you are checking, already it's somewhere moving towards habitual or compulsive use. Then comes the consequences. You use technology despite having consequences in your lifestyle. So out of 5C, if you have 4 in your lifestyle or all 5, then we can say the client or the person have problematic or addictive use of technology. These are certain other standard tools which are used for screening technology use. These are all available freely on the online, but until unless it is used for research, only then we have to seek permission. Internet addiction test is 20-item scale, which again gives severity of internet use. Internet gaming questionnaire is a 9-item scale. Again, it gives a cutoff for internet gaming disorder or healthy use of gaming. Burgeon social media addiction test, again, it gives a severity of media use. Smartphone addiction test, again, it will also give you it's 10-item scale. It's give you the severity of, again, smartphone use. And pornography addiction screening test, which is available both for adult and adolescent, which again can be, which is a common problem. If you see, India stands second in pornography traffics, and it is more on weekend days. So I think somewhere we have to, and we are more concerned that adolescents are also exposed, or adolescents as young as 13 and 14 are into the habit of watching pornography. So there is a need for a lot of awareness in this context. Now, what simple advice we can give, assist yourself for use of technology. For physical health, we advise take frequent breaks. The break should be minimum after 30 minutes of screen use, and that can involve blinking eyes 10 times, moving head forward, backward 5 times each, so the neck strain can go off. Move wrist clockwise and anti-clockwise 5 times each, so that because of browser and all, you can avoid carpal syndrome, you can avoid tennis elbow syndrome, as well as other fatigues. 60 to 90 minutes physical activity is recommended for adults as well as for adolescents also. Avoid binge watching. Binge watching is a common problem, and the criteria goes if you watch more than 120 minutes in one go for recreational purpose, or more than 3 episodes in one go, then you are meeting the criteria for binge watching. The simple strategies is take a 10 to 15 minute break after each episode rather than continuously watching it. Schedule your time for sleep. At least we advise 30 to 40 minutes before sleeping time, no mobile use, because what we have seen, if you use mobile at bad time, it automatically takes away 60 to 90 minutes of your sleep. And sometime in young adults or young adolescents, it goes up to 180 and more than that also. So simple advice, if it works, it brings a lot of change. Minimize delay for sleep and meals, and restructuring the days and academic works. Till now, I think the mental health, we talks about sleep hygiene, but in digital interventions, now we started talking about digital hygiene also, which all of us should reinforce and make aware of ourselves, which includes frequent breaks, which I already told you after 30 to 40 minutes of screen use. Schedule meals, at least 3 meals a day, which we find a common problem among adolescents. They don't take meal, they're more in junk food, which leads to obesity and other issues also. Recommended advice is after 45 minutes of headphone use, take a break, though empirical evidence still has to come on. These are recommendations. Bring indoor and outdoor physical activities. Take care of self-hygiene. And what I want to say, because of COVID time, the leisure time definition has changed. Now we are no longer using leisure activities. We are using more digital leisure activities. So sensitize this kind of word, that avoid digital leisure activities, move toward leisure activities, which can bring more communication, which can bring more eye to eye contact, which can bring more verbal and non-verbal communication. Fourth, I think this is most important in digital hygiene, is digital fasting. Fasting is part of our culture, but now we have to promote digital fasting also. Like whole family should decide at least 1 or 2 hours without technology, and they should schedule certain times that they would not use technology, and that time will be used only for recreational, only for communication, so that they can understand each other also. And sometimes if the family is quite motivated, they can take even 1 day off per week for digital fasting, so that there is a family rule comes up. Because what we are lacking is, we are giving a lot of advice to our adults or to adolescent, but there is no family rules. So I think these kind of techniques decrease digital leisure activities, bring more digital fasting, will bring a lot of family rules and promote healthy use of technology. And the last is digital burnout. Though all of us are professional, all of us have to be on technology, but check if your technology use is contributing toward fatigueness, if your technology use is contributing toward exhaustiveness, if your technology use is contributing towards decreased productivity, then you are suffering from digital burnout. And the right strategy again goes digital fasting, decrease leisure activities, have more offline time, and have a good sleep. So these are some simple brief intervention advice which can be shared with anybody, or which we can use in our day-to-day lifestyle also. These are another things, like as a part of our shut clinic, we have developed one app also, which is available freely. Again, it helps the community or anybody to screen their technology use, as well as to go for various self-help strategies also. So this app can be recommended for anybody. And this one more link is here, where we have all our information material which we evolved as a part of our clinic activities. You can recommend this link also for any kind of information material to your clients or to any youngsters or anybody whom so you need. Now I think it comes, another thing is cognitive behavior therapy, which again goes with the 4 domains. I think advice goes like monitor thoughts. Because of time constraint, I may not go into the details. I will just briefly touch upon the main aspects of CBT. Monitor thoughts, identify thoughts that trigger addictive behavior, which I told, like it could be blaming, it could be excuse, it could be rationalization, or it could be minimizing, and learn new coping skills. And generally it goes for 3 to 4 months, and approximately 12 sessions weekly goes for the CBT. So there are 3 phases of intervention. One is behavioral modifications, cognitive restructuring, and the relapse prevention. And I think in the behavioral intervention, the main strategies goes, advise the client to maintain a daily log of internet use, which can be done as a form of diary, like days, events, online activities, and duration. Establish the baseline for treatment. Pinpoint the situations, trigger events that contribute to online activities. And when clients spend time on giving to on, like for example, this can be the situation which are associated with technology use, and help them to understand the impact of online activities. So these can be the domains for behavioral modification. Then comes help the person to recognize, manage, and organize the time spent on online. Use external stoppers. Sometimes people use software also, because nowadays there is a lot of demand among parents that what are the best software to control the technology use among the adolescent. Because sometimes parents boost off that their young child of 2 years or 3 years can easily open the YouTube, and they can easily open the channel also, which is, I would say, sometimes it may be a boosting off, but it may predispose the child for various deviant content on YouTube. So what we generally lack is, we don't install kid YouTube. We install YouTube for adults, and which the child also use, adult member also use. So that way we are predisposing the child to get exposed to various aversive or deviant online content. Stop navigating to specific sites. And generally the advice goes for children also, like they have to use 3 strategies. One is stop, think, and connect, because children have a curiosity to see every new site or every new message. So advise them that whichever new message come from unknown person, first they have to stop, should not respond to it. Then secondly, think about the reliability of that message. If they think that message is reliable, then they can connect to that message. So stop, think, and connect is a very good brief intervention for children to avoid any kind of cyber crimes. Stop navigating to any specific sites, use of any reminder keys, and develop other offline activities and hobbies. Then other techniques which comes like train at least in terms of relaxation training for anxiety in social situation, which can be the reason for use of online modality. Because one case we found the person who has social anxiety had got developed excessive use of Facebook or social media, but even in the online platform he started feeling anxious because he was not getting likes or he was getting negative comments. So what happened? The social media, social anxiety got converted into virtual anxiety. And the only strategy which was left with this person was to change the social media platform. So we have to train them in working on psychological reasons so that they can reduce the technology use also. Sometimes mindfulness can be also one strategies to work on their psychological issues. And assertiveness and coping with urges, like we say, like there are cues for substance use. When we say most of the time that in alcohol or in substance use the work goes on craving management, and I think this craving management has very much relevance in technology use. So you might have seen, if your person next to you is using technology or smartphone, you can't resist your use of mobile phone for not more than 5 minutes. You will also start using it because the cues are available. If the net connectivity is very good around you, you will definitely use that net connectivity to browse all the sites and all. So all these cues which are important also require cues management and craving management for technology use also. So then comes the cognitive restructuring part, which goes with the standard things like we go with ABC analysis, which include antecedent, belief, and consequences. Antecedent events could be environmental reasons, could be as simple as going to the school or academics are not important. Belief is I am nobody, I can never study well, nobody will ever love me. It's might better to spend time on online friends. And here I would like to highlight that all of us are lacking the expression of affiliation need. Because of technology, everybody is busy in online chats. There is no communication happen between the parent and the children. There is no communication happen between the family and the other people in the environment. So all of us fulfill that, compensate that need for affiliation, compensate that need for connectiveness through online platforms. Even for like adolescent, he play games more because he feels I can interact with my gamer friends. I don't get that opportunity to interact with my parents. Especially in one family, when we gave one task that the family should spend 1 hour together as a part of assignment, the family was, after 1 week when they came back for a session, the family was very much puzzled. They said that we spared 1 hour every day, but we didn't know what to do in this 1 hour because there was no cues, there was no habit to spend time together. And that's why we are moving towards the online technology and friend. So this means a lot of issues are there in our families, in our social environment, which we have to work. And the last is consequences. Excessive use of internet may leads to anxiety and other things which we have to manage. And this ABC analysis will further guide for use of CBT. And the last phase comes as we goes in substance use. Here also relapse prevention comes. Identify what are the triggers for online binge, because it's very difficult, because in substance use you may have abstinence, but in technology we don't have abstinence. Only pornography I use abstinence, but rest of the time we don't use abstinence, we bring balance. So it means cues are available, stressors are available, so there is always a risk for relapse also. Reduce harm associated with online use. Are there identify again triggers based on mood, times, or any game or activities? Or are there any triggers for online activities or any social media platforms, and focus on client strengths. And these can be the change plan worksheet for person. And these are some of the, again, as we started with brief intervention, these are some guidelines from American psychiatric pediatricians, like for how much we should allow the use of technology. Both WHO and American Association of Pediatrician recommend no screen use below 18 months of children. Like for first 18 months, no screen use for children. But I think you can see the contradiction here. Child doesn't complete his or her first blink in this world. Parents take a photo and put on the social media. So I think that much is the awareness. That's why we are working with gynecologists also. We thought we should sensitize gynecologists also, so that they can sensitize the young mothers that how much they have to use and how much use is permitted when they are taking care of the child also. So again, 18 to 24 months, again, the recommendation is no screen use, avoid screen use. Again, go for verbal and non-verbal high quality programs with the children. For again, children between 2 to 5, limit screen use to 1 hour, or it should be less than that. Again, it should be more qualitative, verbal and non-verbal communication. And for children above 6 years, establish consistent limit and help them to build up control use. And that should also be corroborated or should be complemented with family rules for adults or member of the family also. Similar sort of advice is given by WHO also, which also says up to 4 years, screen use should be less than 1 hour, which we find it very difficult to control in Indian setting. They recommend 180 minutes of physical activities. Nowadays, because of COVID scenario and because of other things, it's become very difficult, but we should, whole family should exercise leisure activities, not the digital leisure activities, so that they can build up control. So I think the last message goes, again, I think this is 3R approach. Like again, if the person recognize signs of addiction, which can be craving, control, compulsion, coping, and consequences, or it could be preoccupation with technology use, loss of control, and the third is use despite knowledge of consequences. If these signs of addictions are there, there is a need for repetition of advice for young children, for adolescents, even for adults. Advise digital fasting. These are catchy terms. People will remember maybe for 1 year, maybe for 2 years. And if they remember, definitely they will exercise also. So repeat digital fasting, repeat digital hygiene, promote hobbies and alternative pleasurable activities, and advise them to minimize digital leisure activities. So 3, digital fasting, digital hygiene, and digital leisure activities is the commonest advice which can be given to anybody, and it will make an appeal to them. And in case all these 2 things doesn't work, then refer them for treatment, maybe for psychological reasons and maybe for other addictive issues. With this, thank you, Dr. Mahesh, for giving me this opportunity. And these are my mail. If anybody wants to write to me, I will be willing to share anything, whatever they request for. Thank you.
Thank you, Dr. Sharma. That was a brilliant summary in a brief time of all the behavioral techniques that we can use for our children and adolescents who are not using technology healthily. Dr. Roshan is my co-chairperson. Dr. Roshan, would you want to summarize, please? Okay. Dr. Roshan seems to be offline at the moment.
Dr. Roshan, please unmute. Dr. Roshan? Anyway.
Okay. Do we have any questions from the listeners of the audience? Dr. Sharma, then can I take the privilege of asking a brief question?
Yeah, please.
If suppose parents bring an adolescent to the shut clinic after having gone through local doctors and counselors and fail to make any redressal, how long do you think would it take for an adolescent to be able to get back into the healthy use of technology?
I think It depends also on other factors also. One is the motivation of the adolescents to work on technology use. Since most of the adolescents which we seek consultation with us, they are in the denial mode. It's the family, because of family pressure, they are with us. So it takes away a lot of our time to motivate them and to rationalize them that this kind of help will also help them in various domains of life. Then second thing we have to work with is the family, because family has blamed the child so much. It seems like child has a problem, but family is doing whatever best they can do for the child. So family also require a lot of change in their communication, lot of change in their interaction, as well as in terms of reinforcement and acknowledgement. Because sometimes child complain that I have never got acknowledgement from my parents, but I get a lot of acknowledgement from my friends who are my online friends. So then it comes the family work. So and then thirdly, there would be other psychological reasons, because sometimes we have seen ADHD is also reason which affects the use of technology, or there could be other stresses in the child lifestyle. So then we have to work on psychological reasons also. Since my experience goes with the children where I seen some progress, almost it took 3 to 6 months to bring them to a pattern of 3 to 4 hours of use. When I started seeing them, they were in the 10 to 12 hours. I brought them to 3 to 4 hours with good family support, with good motivation. It took me almost 6 months.
Okay. So 6 months to bring them down to 3 to 4 hours from 12 hours of use.
12 hours of use. So it means it's a challenge. It's brings a lot of other factors are there which we have to maintain. And since everything is in the environment, since you are working with the family, so there is always a challenge and there is always a relapse.
That is it. So it's a big challenge to deal with such patients. So there is a question in the chat box from Dr. Ranjan Bhattacharya. When would you refer the patient for additional medication option?
We have referred when we found significant other psychiatric issues are also there. Which we find like can't be is not possible to manage through our behavioral or psychological help. That time is the case, or sometime it maybe we screen out in the beginning itself, and we advise them to start the pharmacological management also along with our psychological help also.
Right. So it's what sort of comorbidity do you usually see? I think it could be ADHD most commonly.
It's ADHD, impulsivity, sometimes conduct issues also we see, and more issues comes in the affective disturbances.
Right. Okay. Dr. Konjam, you were raising your hand. Okay. So another question that has come from Dr. Shyam Kumar Lashram from Manipur. If a mother gives her phone to a 2-year-old child on the pretext of not disturbing her, how safe do you think that is?
I would say because we do have to, I think we are building up evidence in this regard, but my experience is that it's better to avoid use of mobile phone to distract the child at this age level, better distract her in other offline activities. And because young child exposure to this kind of device will also increase their preference for this kind of online devices, and sometimes it may lead to increased use in the young children also, and which may have a longitudinal effect, but we have to have empirical evidence in this regard.
Right. Dr. Konjam, you were raising your hand. Do you have a question, please?
Yes, good evening, Manoj Sharma.
Yeah, thank you.
Beautifully presented. I just want to ask a question. In places where there is law and order situation, internets were off for a few days to maybe weeks. Does it really help in this when they were offline from the internet? Do you think this will help? And another one, during the COVID situation, in the lockdown, many people are staying at home. So time spent with the parents, does it really help? And then it really helps in this overuse or addiction of these this internet use?
Especially in relation to your first question, the type of response which we are going to get depend upon individual to individual, because there may be each individual has different pattern of use. Each individual has different psychological and other predispositions also. Because sometime when there is a ban come, when there is no internet, users have withdrawals because they don't know how to structure their free time, because internet has become a modality to structure the free time. Once there is no internet, they don't know what to do. But if they have some other activities during that free time, definitely they enjoy that time also, and they are able to they have minimum withdrawals because of lack of availability of internet. But there is another domain which we have published is internet connectivity, which is related to the internet ban. Though internet is available, but internet connectivity goes down, it also brings irritability in the users, because they feel I'm not able to finish my work, or I'm not whatever they are in, whether it is game, whether it is entertainment or any activity, they feel it will take long time. And somewhere the speed has increased our desire to execute thing very speedily. That's why people are moving from 4G to 5G, because they feel the speed will be more. And most of the people, if you find, will be there where net connectivity is very good. People don't like to be places where net is very slow. So there is a different domain and the way the people react. But during COVID time I think is a high time where family can work in for family activities and for family dynamics or other issues. But somehow it is not happening. Some of the family definitely it may be happening, but in majority of the family, what is happening? All people are using this time to be on technology also. The proportionate increase has happened in technology, which has disturbed the communication pattern, which has brought other negative issue in the family also, because parents become vigilant about adolescent use and they become more judgmental. Adolescent want that a lockdown should get over so that my parents start going to the work, so at least I can enjoy whatever I'm doing. But parents are more concerned that during this lockdown they should make sure that child finish all the syllabus and he should score good marks. So that's why we are saying there is a need for communication between the family and the young children, so that these issues can be sorted out and they can have a good quality of family life.
Thank you.
Okay. Dr. Roshan, do you want to take over now? You're the co-chairperson. Do you want to summarize and complete this session?
Yes. Yeah. Thank you so much, Dr. Manoj Sharma. You have presented very extensively on the behavioral approach for addiction. And something that I like to mention is regarding the contingency management. I think contingency management is also very relevant for the behavioral approach in addiction. Like we can use so many techniques like voucher-based reinforcement technique and the price incentive contingency management. This, if you mention these things in your presentation, will be very, very informative to all of us. And with these few words, let me say thank you to all. And thank you to all. Thank you.
Thank you, Dr. Sharma.